Thank you for the chair, and thank you for the organizers for having me here. I'm going to be talking about left main optimization, and it's going to be specifically about show me the numbers. Numbers is what we are going to deal with. We've been talking about left main stenting since yesterday now. Yesterday, the whole thing was use less stents, just one stent. Do not use a second stent. Today, we are arguing about using two stents and which of the two is the best method for using two stents. How do I go next? Yeah. Luckily enough, we don't have surgeons here, but otherwise the debate also could be whether PCI or CABG is the best for left main stenosis. We still have to achieve a consensus there. And there are obvious factors which will favor a PCI or a CABG depending on your patient or clinical factors. You have anatomical factors, you have very, very practical problems like a frailty index if the patient is frail. If there's a prior CABG, we do end up doing PCI in those group of patients. So if we have to do PCI, how do we go about this? Now, as has been already mentioned in the previous talks also, we have the EBC main giving us data not long back and telling us that provisional stenting is the best. It advocates provisional stenting. So then, what do we do? In the very same EBC main data, 22% of the patients had to eventually require a second stent. So in the very same trial, we had 22%, not a very big number, but a sizable number, where we finally happened to do a two-stent strategy. There's enough data in the past. Park et al. In the randomized trial, we have the Noble data, we have the Excel data, all of that showed close to 35 to 54% of the time PCI group had to use two stent strategies. So what does that leave us with? We are going to be compelled to use two stents, although we might want to use only provisional in the left main as an ideal choice, but many a times we will be compelled to use two stents, if not upfront. How do we do it better? Because we are competing with the Lima. So if we have to compete with the Lima, we have to optimize it as best as we can. So obviously, intravascular ultrasound or OCT or some form of intracoronary imaging is going to be one of the factors which will help us optimize, and rightly so. For the same reason, now with the latest guidelines, it's a class 1 indication if you're doing left main PCI. What do we see in optimization? When we use intravascular imaging prior to the stenting, of course, it will help us in many ways, but more importantly, a final run after your stent has been deployed. A final run is going to be extremely important. The common factors which we see are for edge dissections, which are critical. We have hoping that we have not ended in a plaque burden which is more than 50% or 40%. The stent margins are not ended there. There is no tissue prolapse, there is no malapposition, and there is no adequate stent under expansions. These are the common things which we see for post-stenting after we have done, especially so in a left main situation. So when we see the final result, may it be with IVUS, as I said, apposition, edge dissection, full expansion, and lesion coverage to avoid a geographical miss is what we are seeing. May it be with IVUS or may it be with OCT. One may be scoring over the others. Some tissue prolapse is better seen. Dissections are more commonly seen with OCT, but more or less one of the two needs to be done. When we see all these factors for optimization, what we do know today is stent expansion is going to be your major predictor. So if stent expansion is your major predictor, compared to your apposition and your edge dissections, your stent expansion is something which you should be aiming for to get optimal results, especially in a left main PCI situation. You can do that either ways, by an IVUS, where you do it manually, or there are some algorithms in the OCT, maybe by a tapered or a dual reference method, where you can get your stent expansion rates. Because of the same reason, this trial was done way back in 2011, a decade before, where the same group, Kang and Kim, did a trial on 403 patients, because of which we got these magic figures or the magic numbers, which we have been practicing all throughout. 5, 6, 7, 8 is what the numbers were, and these numbers, if we were able to achieve on an IVUS or an OCT, we knew our restenosis rates were lesser and target lesion revascularization rates were lesser. And hence, for a case like this is what we would achieve, and we were happy with what we used to get, the stent areas in the particular areas where you measure the MSAs. It was seen that the discrimination ability of these figures were poorer in the long-term outcomes, were not studied, because mind you, it was just a 9-month data. So therefore, also in the Noble trial, it was seen whatever these figures we achieved had no actual clinical relevance. So based on that, this was a trial which was done very recently, published in Circulation in the January 2024 edition, where the same group, again, Kang and Kim, did the same study again in the same center from Seoul, where the objective was to revise this criteria and at the same time use it for upfront 2-stent strategy. The strategy that they chose was the DK crush, and this time it was a 5-year clinical outcomes data. The IVUS measured MSAs were panned, or they were distribution was seen for each of the 3 segments: distal left main, LAD ostium, and LCX ostium. What they achieved as the cutoff was slightly more than what we were fed with all these years. The left main, it was 11.8. The ostial LAD was 8.3, and the ostial circumflex was 5.7 millimeters square. So this was the cutoffs beyond which the rates of target lesion failures were more if you do not achieve these targets. So you have stent under expansion criteria of the LAD MSA, it's less than 8, LCX MSA less than 5.7, and left main MSA less than 11.8. What was interesting also was the LAD and LCX ostium, if they were under expanded, that led to increased events compared to the left main or the distal left main MSA. If you fail to achieve 11.8, the events were not clinically significant or statistically significant. So this was what the final flowchart or the groups looked like. The group 0 had where you had a good expansion both at the LAD and the LCX. Group 1 you had good expansion in either of the two, that's the LAD or the LCX, but the other one you failed to achieve an adequate expansion as per the cutoff. And the group 2 where you failed to achieve expansion in both the groups, that's the LAD and LCX. And when you saw the results, the under-expanded group fared significantly worse compared to the fully expanded group. That was a statistically significant result, which we are seeing. If you fail to achieve the cutoffs in both the LAD ostium and LAD LCX ostium, you fared worse. Now, what was interesting also in this study was if you have a MSA of the distal left main, that could not predict events as per this present study. But at the same time, you need to remember it was a very large cutoff. 11.8 is a very large cutoff for the MSAs. The distal outlet lumens, that's the LAD and the LCX ostiums, were more prognostically important compared to the distal left main lumen. So where does this leave us for the best practices in 2024 today? One, once you have done or decided for a 2-stent strategy, further optimization is always required with intravascular imaging. Beyond the typical parameters which you check for intravascular imaging, stent optimization with the form of MSAs, either an absolute minimal stent area or a relative expansion, or both, is what you should be aiming for. Bigger is better. The minimum criteria now are changed to 6, 8, and 10. That's your LCX, LAD ostium, and the distal left main MSAs. The optimal is even more, 7, 9, and 12 is what the recommendation is after this trial. The criteria should be modified for a smaller caliber vessel where you can use the relative MSA criteria. I'm going to leave you with this chart or this diagram, which is going to be the most important diagram of my talk today. Single stent still remains the best, but as you all saw, we are compelled to use 2 stents many a time. And if we are going to use 2 stents, this is what we should be aiming for. On the chart above, you see the original criteria where you had the 5, 6, 7, 8 for the non-Western groups, whereas the Excel criteria for the Western people is what was proposed till recently, and the relative MSAs you had was for the 90% compared to the reference diameter. Today, what we leave with is these are the criteria. Minimal you should aim for is 6, 8, 10, and the optimal would be even more, 7, 9, 12 MSAs. Slides are gone, but otherwise you have a relative MSA where you can calculate the stent expansion index, where you can measure the MSA at the vessel area at the MSA site, which should be more than 40%. So that's what my talk is going to be, and that's how we need to chase the numbers today. Thank you very much.